This is something that we need to embrace in our Native communities. This is a human disease. We need to have the freedom to speak about it. The more ready that we are to talk about it, to speak to our youth, the more prepared that our Native communities are, the stronger that we're going to be able to be. We care and we love for our people, so that's what needs to come first. This is something that we need to embrace.
As the HIV/AIDS principal consultant for the Indian Health Service, I direct the National HIV Program. Among many of its projects, the HIV program has a large, expanded HIV testing initiative that includes IHS, tribal, and urban partners. We link our partners to training, resources, policy, and the growing network of other implementers across the system. The program also collaborates with many federal agencies to leverage resources. Although we have made significant progress thus far, much more work needs to be done.
You know, I think that there is a huge problem when you look at HIV rates in the United States and when you're looking at HIV rates broken out between different ethnic groups. And you see other ethnic groups or subpopulations having fairly consistent HIV rates or rates that are actually dropping, and then you look at other populations where HIV rates are continuing to rise. And that's the case with American Indian and Alaska Native people.
HIV is rising in women, in heterosexual high-risk women. And if you look at some of the charts right now, the data charts back in 1990, for instance, you look at the transmission figures and heterosexual transmission was about 3%. That's now moved considerably higher. And so there's a big shift in the data that has occurred that I think people are unaware of, and therefore they continue to think that there isn't a risk.
I decided to get an HIV test at the end of my second relationship when that former boyfriend had disclosed that he had AIDS. I wasn't very educated on who needed an HIV test or why. I had a lot of misconceptions about who I thought were the people who needed to get HIV tests, and I just didn't feel like I was someone who fit into that category. I thought that, you know, you either were promiscuous or you had to be an IV drug user, of which I felt that I was neither.
Our goal is to explain that to them and get them to work and understand, you know, a role of a virus is to infect, and it doesn't care who it's infecting.
I work for the Indian Health Service, which provides services in 2 of the 4 districts on the reservation. There are 2 other clinics that are operated tribally that have their own tribal PHMs, but we all try to work together, doing a variety of things that public health nurses do. Immunizations, well child, diabetes, chronic care, and we've just recently rolled out our universal HIV screening program.
So the HIV Center of Excellence was founded in 1996, and really its mission was to develop a clinical program that would provide treatment and comprehensive care to American Indian and Alaska Natives who were HIV positive.
I'm the director of the CASE Center, which is funded by the Centers for Disease Control. And we are on a 5-year grant to provide capacity building assistance to communities to help them use our community readiness model to develop HIV prevention strategies that are consistent with the readiness level in their community. That helps them to not waste their resources and to move quickly ahead. We also go out and we provide trainings. We help the communities to develop action plans that are consistent with their culture. And we do a lot of social marketing. We do a lot of action plans to help communities do their own social marketing in their own language, their own designs, in their own way. And we thoroughly love what we do. We all have different cultures, we all have different kinds of resources, we all have different political systems. So if anything is going to be effective in a community, it has to be specific to that community.
I think that going to the communities and asking them how we can help them solve their own problems is the biggest thing in building a successful HIV or STD or sexual health program.
I would definitely tell you that one of the first things you need to do or would want to do is conduct a short survey or maybe some sort of focus group or panel to get a level of the community readiness to receive messages.
We had a community dinner, we had a speaker, actually we had several speakers, experts, to just talk about their experience. We had a HIV positive Native American lady come and tell her story and how she was infected and how innocently that happened for her, and other folks that were talking about some of the practices of our younger people right now and how they're even at greater risk than folks were in the past, and that this is important to identify to prevent the spread and to prevent people from getting sick.
We have a community health program. We go out into the communities and do projects for HIV screening with the OraQuick tests. One of the good success stories that we've had is that we have been able to train other community members to do OraQuick HIV testing. And it's not only from our community but from other reservations as well that we have trained, so they can start doing HIV testing on their reservation.
The HIV program in Mescalero, we do routine testing of our patients when they come into the outpatient clinic. The testing that we're doing at our facility, it's the HIV test that goes to the lab. We don't do the rapid testing, we don't do the oral testing. Basically our decision was because of the cost. If we brought rapid into the facility, it was going to be a little more than what we were paying our referral facility to do the testing. It had a lot to do with staffing, and that's one of our issues, is staffing. In order to make the decision on the HIV testing for a small facility, I would absolutely have them look at both the cost and the staffing.
If you start out with an entire reservation that hasn't been tested and suddenly everybody comes due for a test, it could very easily overwhelm what resources we had. So we put together a plan so that we're doing it as patients are already needing other lab work. We basically did some policy writing ahead of time, which allowed us to do a lot more testing in a more expeditious manner. We don't require written consents anymore. We can just put an order in, and as long as we have the patient saying that it's okay to do the testing. So we were able to put in an order set, and it works really well with our electronic health records. Our patients are pretty amenable to being tested. I also go to the jail 2 days a week, and we're now providing testing there.
We've run several different community events related around National Native HIV Awareness Day, and those have been successful. We've actually recruited local agencies to actually come in and support us by providing testers to help us deal with the amount of people that we had coming in.
You know, I didn't start out just feeling confident and going out and being able to tell people and talk about my HIV status. I was very quiet and secretive about it. I didn't even tell my family for 3 years.
I think that people have a great stigma when it comes to sensitive issues like HIV and AIDS, and they might tend to think that it's those people or a particular group of people that has HIV or that can infect you with HIV, and that's not true. We are all those people, all of us, each and every one of us.
Well, I think it's important not just for Native Americans, but for everybody to know their HIV status. I think we need to incorporate it into our routine health care. If we do that, then there's not the stigma. Women go in for their Well Woman exams, and they have their regular lab draws. Men have their yearly physicals. It should be incorporated into it.
So I have to look at these diseases as I would cancer, diabetes, arthritis, lupus, all of the other diseases, and to share that acceptance that it's another disease, it's here, it's going to be here forever. We need to start treating it as a disease and not as a plague. We have to remove the barriers that have been thrown up about HIV and AIDS, as well as other diseases. If we remove those, then the compassion can come back to life.
Well, statistics prove that younger people, especially 18 to 24, are highly sexually active. And it just makes sense that you would want to have prevention messages encouraging people to reduce their amount of risk that they have in their lives, because the long-term results of having a sexually transmitted infection or disease such as HIV is costly.
But young people everywhere tend to not perceive themselves at risk for anything.
And we were really focusing on youth. They have the biggest burden of disease as far as STDs go, and also continually rising rates of HIV. And so we asked them what they knew about HIV and STD. We tried to build an overall sense of community where people can share stories.
Well, most young people today, especially all the ones I've ever encountered, all have access to mobile phones, and they all have access to the internet. A great majority of them do. And they have access to the internet through their mobile phones. Text messaging is a technology and a communication method that is very, very widely used within younger people, the communities of young people.
Fortunately today, in this world of new media, we have all kinds of websites that are available to help communities to find resources and to collaborate and to network with one another. Indian Health Service has a wonderful website, so we have a lot of resources that are available to us that we didn't have 10 years ago.
We've started receiving funding several years ago to develop a national telemedicine, IHS telemedicine network. And then we have received funding to implement the chronic care model in an HIV primary care setting, both here and through that telemedicine network. But what it allows for are consultations to be sent via secure server for providers out in the field who may be taking care of HIV positive patients to send questions to experts, send clinical questions, pictures of rashes, other issues, and get that feedback so that patient can be taken care of in their localities. I hope that as we sort of start to build a collaborative within the ITU system of people who are taking care of HIV positive patients, people interested in preventing HIV positive patients, all the testing, that it will be an avenue in which we can communicate more frequently and in a more effective manner so that we can share sort of the wealth that we've developed over many, many years here, because it doesn't occur overnight.
If you came to me and wanted advice on starting an HIV program, I would tell you to begin with your personnel in your facility. Teach them the cultural aspects of teaching Indian people. Then be comfortable with yourself to teach others about HIV and how it's contracted, and that it's an easy test. And then the prevention as well. Teach your providers, your medical staff, that it's not that difficult to tell somebody their results. Do not shy away from it.
When I work in my general medicine clinic, I basically tell patients, CDC recommends everybody get tested for HIV, and we're going to do that today. And just like we're going to check your cholesterol or we're going to check anything else, and I just say it matter-of-factly. I'm training the nursing staff to say it matter-of-factly, and then we can engage in those conversations about prevention, just like we do for any other chronic disease.
Well, I think it's important that, first of all, that the practitioners on both sides work together. I think that's a really important message. And I think one of the things is being able to see that understanding of the holistic wellness, being able to see the physical, mental, emotional, and spiritual connections, how everything is tied together. So the whole idea behind collaborating in terms of HIV is that there's a lot of traditional people out there that can really assist in that way. So I think the collaboration is vitally important. Sometimes people talk about alternative medicine, for instance, but I kind of prefer the term complementary medicine because it gives you that feeling that they're working together.
We collaborate with the county health department. There's an HIV case manager there. We also collaborate with the local Spokane County Regional Health District. We collaborate with our tribal clinics. We've developed a kind of a public health group which has really grown as a result of our H1N1 issues. We collaborate obviously with the National IHS program.
Our Native American Pathways program has had different looks over the years. We at one point were providing some comprehensive case management services that were pretty intensive. You know, we shifted to community education, all the time maintaining counseling and testing during that time.
I don't anticipate there will ever be an end to the collaboration between the National Indian Health Board and the Indian Health Service because they both share a focus and a mission to improve the quality of health care for American Indians and Alaska Natives.
I think when you're looking at health disparities and health equity, the fact that our HIV rates are continuing to rise means that we have to address it.
Fears are normal, but this isn't it's not the end of the road. We're strong and we're stubborn and we're humorous and we have our ways of dealing with things that are difficult. And this is something that we need to embrace in our Native communities.
The IHS HIV program will assist providers and communities to prevent the spread of HIV. I hope you will take every opportunity to raise HIV awareness in your community, to educate others about HIV prevention and risk, and to use the resources available to take control of your health. I'm looking forward to the continued relationships between the IHS HIV program, Native communities, and all our partners as we work together to address HIV.